Good evening, students. In this lecture, we'll be discussing hepatic diseases. The objectives for this lecture include the following: discuss the basic anatomy of the liver, explore the physiology of the liver and apply liver physiology to various manifestations that may be seen in the patient with liver disease, discuss the management of liver disease manifestations, develop an understanding of assessment techniques and laboratory tests that indicate liver disease, analyze the different forms of hepatitis, discuss common liver diseases including cirrhosis, hepatic cancer, and hepatic abscesses, and finally apply treatment methods and the nursing process to the patient experiencing liver disease. Let's begin with some anatomy and physiology review. Here I've outlined the basic anatomy of the liver as well as surrounding organs. The key here is to notice the proximity of the liver to other abdominal organs. This becomes important when thinking about the manifestations of liver disease. Inflammation of the liver is likely to cause symptoms in surrounding organs. Here's a picture showing the vasculature coming from the liver. Just below the liver, you have the hepatic portal vein, which branches into the left gastric vein and down into the superior and inferior mesenteric veins. You also have a branch going to the spleen, referred to as the splenic vein. Overall, the liver has approximately 500 different metabolic functions. However, we're going to focus on 6 different functions of the liver. These include bile formation, bilirubin excretion, drug metabolism, vitamin and iron storage, ammonia conversion, and nutrient metabolism. As a review, remember that proteins, carbohydrates, and fats are ultimately converted to acetyl coenzyme A, which enter the Krebs cycle and ultimately move into oxidative phosphorylation for ATP production. Protein metabolism is particularly important in the liver. Protein is hydrolyzed into amino acids, which go to the liver and can be used for either synthesis of proteins such as albumin and clotting factors. These two are the most important, among other things. Or they can be used for oxidative deamination, where they form ammonia, which is converted to urea in the liver. When the amino acid is broken down here, we use the carbon skeleton to develop pyruvate or acetyl coenzyme A, which can be converted to energy, glucose, or fatty acids or ketones. The fat-soluble vitamins A, D, E, and K, as well as vitamin B, are stored in the liver. The primary function of vitamin A is vision. The primary function of vitamin D is absorption of calcium. E functions as an antioxidant and protects cell membranes. K is very important in coagulation. And B is important in metabolism, nerve function, vision, and skin. Additionally, the liver is important in storage of iron and copper as well. Just as a side note, iron is stored in the form of ferritin. Bile is made up of a lot of different components listed here. They are formed by the hepatocytes from cholesterol. Bile functions in emulsification of fats in the intestines, resulting in appropriate absorption of fats. Intrahepatic circulation is an important form of circulation associated with the liver and bile, whereby bile is reabsorbed in the distal ileum into the portal blood and is transported back to the hepatocytes. The textbook provides a relatively complicated description of bilirubin. I'll simplify the process for you here. Essentially, red blood cells are broken down through hemolysis, where free hemoglobin is converted to unconjugated bilirubin. Unconjugated bilirubin is converted to conjugated bilirubin in the liver by uridine diphosphate. This is the rate-limiting step that determines whether or not you can convert unconjugated bilirubin into conjugated bilirubin in the liver. Conjugated bilirubin then is excreted in the stool. Hepatocytes have a high concentration of smooth endoplasmic reticula, enabling the detoxification functions of the liver. Because of this, the liver plays a major role in drug metabolism. So in the liver, drug activation and inactivation occurs. Drugs can be bound to either glucuronic acid or acetoacetic acid to form soluble substances that can be excreted. Also, the liver is important in the first pass metabolism and involves the cytochrome P450 pathway. You may have noticed the cytochrome P450 pathway in drug books. This determines the rate at which an individual metabolizes drugs. And genetically, individuals can be rapid, extensive, and slow metabolizers of drugs. Finally, the liver plays an important role in albumin synthesis. Albumin is important for drug transport in the body. So with liver disease and reduced albumin synthesis, drug transport can be impaired. Now let's discuss some manifestations of liver disease as they relate to hepatic physiology. Malnutrition and anorexia can occur in liver disease, primarily because of impaired glucose and protein metabolism. In these patients, you may notice either hyper or hypoglycemia, as well as decreased protein synthesis. Vitamin deficiency is especially a problem with fat-soluble vitamins due to decreased synthesis of bile salts and storage. Vitamin A deficiency can lead to night blindness, eye and skin changes. Vitamin D deficiency can lead to impaired calcium balance. Vitamin E deficiency can lead to free radical damage and oxidative stress. A deficiency in vitamin K can result in reduced synthesis of clotting factors. And a deficiency in vitamin B can result in altered metabolism. Thiamine is another vitamin deficiency noted in liver disease that can potentially lead to a condition called Wernicke-Korsakoff psychosis. This can be prevented in the patient with liver disease by always giving thiamine before you give glucose. Additionally, a deficiency in riboflavin can result in skin and mucous membrane lesions, and a deficiency in folic acid can result in a macrocytic anemia. Impairment in drug metabolism can occur in drug activation or inactivation, a change to the molecules capable of elimination, impaired metabolism in terms of the cytochrome P450 pathway, and reduced transport. Jaundice is the accumulation of unconjugated or conjugated bilirubin in the blood. This produces a yellowing of the skin, mucous membranes, and sclera, properly termed icterus. There are 3 different types of jaundice. The terms I've used to describe these 3 types is slightly different than that described in the textbook, but makes a little bit more sense when trying to think about the types of jaundice. These 3 types are pre-hepatic, intrahepatic, and post-hepatic. Pre-hepatic primarily involves unconjugated bilirubin. Post-hepatic primarily involves conjugated bilirubin, and intrahepatic involves a mixture of both. Pre-hepatic jaundice, sometimes referred to as hemolytic jaundice, primarily involves unconjugated bilirubin. This comes from excessive hemolysis or hematomas. Essentially, if you have increased red blood cell breakdown, you'll have an increase in unconjugated bilirubin. Intrahepatic jaundice has a variety of causes. Rarer causes include Crigler-Najjar syndrome, which is a genetic increase in unconjugated bilirubin. The problem in this disorder is with the uridine diphosphate that's responsible for converting unconjugated bilirubin to conjugated bilirubin. A very similar problem happens in Gilbert syndrome. Dubin-Johnson and Roeder syndrome are both autosomal recessive diseases resulting in increased conjugated bilirubin. Far more common, however, cirrhosis and hepatitis can cause intrahepatic jaundice. Post-hepatic jaundice is primarily a buildup of conjugated bilirubin. A general rule of thumb is that painful jaundice is associated with gallstones, where painless jaundice is associated with cancer or strictures. The problem here is an obstruction below the liver that results in an increase in conjugated bilirubin. Portal hypertension is a condition in which there's increased pressure throughout the portal venous system, resulting from an obstruction of blood flow into and through the damaged liver. The most common cause of this is hepatic cirrhosis. So basically, if you have scar tissue formation in the liver, there's going to be an increased pressure in the portal venous system. Generalized edema and ascites is due to portal hypertension, obstruction of venous flow, reduced aldosterone metabolism resulting in sodium and water retention, and hypoalbuminemia. To simplify this, think back to Starling's forces. Whenever you're thinking about a capillary, think about it as fenestrated or like a window screen. With increased stretch, the holes in the screen widen. As a result of this, protein can leak out, resulting in a decrease in oncotic pressure. The pressure caused by obstruction and portal hypertension increase hydrostatic pressure. This results in the accumulation of fluid in the abdomen, or ascites, and generalized edema in the extremities. Ascites can be assessed by shifting dullness. This is a technique shown down here at the bottom where you percuss down the abdomen towards the level of fluid. Prior to the level of fluid, you'll hear tympany. Whenever you hit the level of fluid, it'll shift to dullness. A fluid wave test, shown in the top here, can only be assessed if there's a large volume of fluid. This technique requires two examiners. One places their hands in the center of the abdomen. The function of this is to hold down subcutaneous fat, while the other examiner percusses on one side or taps on one side and sees if they can fill the fluid on the opposite side. The ballottement technique involves palpation of enlarged organs within the acidic abdomen. This process is described further in the textbook. Additional methods of assessment include daily abdominal girth measurement and daily weights. The management of these patients with fluid volume overload includes maintaining them on a 2-gram sodium diet. You want to encourage them to avoid table salt, salty foods, salted butter or margarine, canned and frozen foods. Encourage the patients to use salt substitutes such as lemon and oregano. Diuretics can also be used, such as spironolactone and furosemide. It's important to monitor the patient's I&O, girth, daily weight, ammonia, serum creatinine, and electrolytes. Fluid restriction is not indicated unless there's hyponatremia. Bed rest is important because the upright position can stimulate the renin-angiotensin-aldosterone system, resulting in more sodium and water accumulation. A paracentesis involves the insertion of a needle into the abdomen to drain off fluid, much like a thoracentesis. The transjugular intrahepatic portosystemic shunt, or TIPS procedure, involves the creation of a shunt between the portal vein and the hepatic vein. The hepatic vein drains into the inferior vena cava and will divert the pressure from the portal vein into the inferior vena cava. The goal of this procedure is to reduce portal hypertension. Esophageal varices are dilated, tortuous veins that develop from elevated pressure in the hepatic portal system. Varices are prone to rupture and are a source of massive bleeds. The mortality rate can range from 10 to 40%, and this is related to the ability to control the bleed. A bleed from esophageal varices can result in hemorrhagic shock that reduces organ perfusion. To the right, I have an endoscopic view showing the esophagus, and here are the esophageal varices running down the esophagus. Manifestations of esophageal varices include severe hematemesis, melena, altered mental status, and symptoms of shock. Assessment includes ultrasound, CT, and angiography, as well as endoscopy, portal hypertension measurement, and liver function tests. Management of esophageal varices includes the ABCs, airway, breathing, and circulation, IV fluids, and vasoactive drugs. Octreotide is a common drug used in varicose bleed management. It's essentially synthetic somatostatin that decreases bleeding. Vasopressin can act to constrict the splenic arterial bed and decrease portal pressure. It also constricts esophageal and gastric veins. And finally, beta blockers can reduce portal pressure but should be avoided in acute bleeds. In general, patients with esophageal varices should avoid anything that puts pressure on the varices themselves. This includes avoiding straining, lifting heavy objects, sneezing, coughing, and vomiting, as well as salicylates. You should monitor their vital signs, nutritional and neurostatus. Parenteral nutrition may be required, and these patients may require a transfusion or vitamin K to reverse the effects of warfarin. There are several surgical approaches that you can read more about in your textbook. Retention of bile salts causes pruritus or itching. This is caused by the acid content of bile salts. Patients with liver disease can also develop spider nevi or angiomas. This is shown in this top picture. Another condition that can occur is caput medusae. This is the palm tree sign and is distended superficial epigastric veins from portal hypertension. This is shown in this bottom image. In liver disease, clotting factor synthesis is reduced. This leads to an increase in bruising, epistaxis, bleeding from wounds, petechiae, and gastrointestinal bleeding. Splenic congestion secondary to portal hypertension leads to an increased pooling of platelets in the spleen, causing hypersplenism. Hepatic encephalopathy or coma is a neuropsychiatric symptom associated with portal hypertension and shunting of blood from the portal venous system into the systemic circulation. Because of hepatic insufficiency, as well as portosystemic shunting, protein catabolism and GI flora, which produce ammonia, is built up in the blood and therefore builds up in the brain. Once in the brain, ammonia binds to benzodiazepine-like receptors on astrocytes. Astrocytes kind of function as a glue, as well as a connection between nerves and vessels. Once these benzodiazepine-like receptors are stimulated, there's an increase in gamma-aminobutyric acid, the major inhibitory neurotransmitter of the central nervous system. The increase in GABA results in central nervous system depression. The manifestations of hepatic encephalopathy essentially progress through 4 stages. As you progress, the level of consciousness decreases. There are 3 symptoms that kind of stand out with hepatic encephalopathy. The first is asterixis. This is referred to as the liver flap, which is involuntary flapping of the hands. The second is constructional apraxia, which is the inability to reproduce simple figures in 2-dimension or 3-dimension. The third is fetor hepaticus, which is a sweet, slightly fecal odor of the breath. This is often described as smelling like mowed grass. The 2 primary treatments for hepatic encephalopathy are lactulose and neomycin. Lactulose functions to trap ammonia in the feces for excretion. The goal is for the patient to have 2 to 3 soft stools per day. You'll want to monitor the patient for hypokalemia as well as dehydration. Neomycin, along with metronidazole and rifaximin, results in a reduction in the ammonia-forming bacteria in the colon. Administering IV glucose can reduce protein breakdown. These patients will likely need vitamin and electrolyte replacement. The patient's neurological and mental status should be monitored, along with eyes and nose, daily weights, and vital signs every 4 hours. These patients should be maintained in a safe environment and should be assessed for infection. Support the respiratory system by having the patient turn, cough, and deep breathe. Monitor the patient's ammonia level daily. These patients may benefit from a short-term restriction in protein, but long-term restriction should be avoided. It's important also to avoid any sedatives, tranquilizers, and analgesics that are not necessary, because these may stimulate the benzodiazepine-like receptors on the astrocytes, worsening the problem. Finally, flamazanil, which is a reversal agent for benzodiazepines, may improve encephalopathy whether or not the patient has taken benzodiazepines because it targets these receptors. This is a short-term therapy only. Now let's discuss the assessment of liver function. In analyzing the patient history, you want to know if the patient has a medical history of liver disease, substance abuse, psychiatric disease, or metabolic syndrome. With family history, you want to know if the patient has a family history of liver disease or liver cancer. Medications you'll want to be aware of that are hepatotoxic include NSAIDs, ketoconazole, and valproic acid. The main focus of the social history is to explore for hepatotoxins. For instance, you want to know if there's any history of drug or alcohol use, what their occupation is, whether or not they've traveled out of the country, and their sexual history. In general, men who drink 60 to 80 grams per day of alcohol are at risk for hepatic cirrhosis and other liver diseases. Women who drink 40 to 60 grams per day of alcohol are also at risk. In the review of systems, you want to know if the patient's been experiencing any jaundice, malaise, weakness, fatigue, pruritus, abdominal pain, fever, anorexia, weight gain, edema, an increase in girth, melena, hematochezia, easy bruising, altered mental status, and sleep disturbances. Physical exam findings can include the following: jaundice, edema, excoriation secondary to scratching, petechiae, ecchymosis, spider angiomas, and palmar erythema. Exam techniques that can be included in assessing the patient with liver disease include daily weights, a fluid weight test, palpation of the liver, percussion for liver size, and percussion of the upper and lower borders of the liver. Tenderness, noted during percussion, results from acute enlargement of the liver. The following is a simplified method for analyzing hepatic and gallbladder problems. Recall in the previous images, the colors correlate with the issue. So black, in general, corresponds with intrahepatic issues. Red corresponds with pre-hepatic issues, and green corresponds with post-hepatic issues. The prothrombin time, or PT, is the best indicator for acute liver injury. This is because clotting factors are synthesized in the liver. Note, however, that the PT may also be elevated in warfarin therapy, coagulopathy, and decreased vitamin K. The albumin is the best indicator for chronic liver injury. Albumin is synthesized in the liver, and the half-life is approximately 20 days. Albumin is low in what's referred to as the Ascites diseases. Cirrhosis is one where you can't build albumin. Nephrosis is another one where you spill excessive albumin. And finally, gastrosis is where you lose albumin or there's excessive malnutrition. A protein gap is calculated by subtracting the albumin from the total protein. A protein gap greater than 4 means that something else is making proteins, especially immunoglobulins. Examples of conditions that increase immunoglobulins include sepsis, autoimmune disease, HIV, multiple myeloma, and most importantly in this situation, hepatitis C. The AST can be elevated in liver disease, but remember that it correlates more with muscle. If the AST is elevated, it's important to check a creatinine kinase. An elevated creatinine kinase indicates rhabdomyolysis. This condition involves excessive muscle breakdown, and creatinine kinase is the byproduct of muscle breakdown that builds up in the blood. ALT corresponds mainly with the liver, so it's elevated in liver conditions such as cirrhosis, autoimmune hepatitis, acute viral hepatitis, shock liver, and acetaminophen toxicity. Alkaline phosphatase is elevated in either bone or liver disease. When the ALP is elevated, a GGT is checked. An elevated GGT corresponds with biliary disease, whereas a normal GGT corresponds with bone disease. When looking at bilirubin, the total bilirubin corresponds with unconjugated bilirubin as a pre-hepatic problem. The direct bilirubin corresponds with conjugated bilirubin and is a post-hepatic problem. In diagnostic imaging, an ultrasound can give you structural but not functional information. If you add Doppler, you can look at vascular patency and function. A CT is excellent for looking at hepatic masses. An MRI is good for looking at vessels, ducts, hepatic tissues, and is best for diffuse diseases like cirrhosis. Laparoscopy is indicated for a direct examination and facilitation of biopsy. Liver biopsy involves the removal of a small amount of liver tissue, usually through needle aspiration. Indications include the evaluation of diffuse disorders of the parenchyma to diagnose a space-occupying lesion. The most common complication of liver biopsies is peritonitis. In our final section, we'll discuss diseases of the liver. Hepatitis is a systemic viral infection in which necrosis and inflammation of liver cells produces a characteristic cluster of changes. All of the manifestations of hepatitis look the same. They look just like a cold, with fatigue, malaise, nausea, abdominal pain, poor appetite, and the one difference, jaundice. There are 5 known forms of hepatitis. Hepatitis A through E. Hepatitis A is transmitted through the fecal-oral route, usually from contaminated foods or liquids. This is typically in an overcrowded environment with poor sanitation. Prevention of hepatitis A includes good hand washing, safe water and sewage control, immunoglobulin within 2 weeks of exposure, and the hepatitis A vaccination. Management of hepatitis A includes bed rest, small frequent meals, support coping, avoiding alcohol, education, IV fluids with dextrose, and progressive activity and exercise. Hepatitis B is transmitted through blood. The most common populations at risk include healthcare providers, those who work in hemodialysis, IV drug users, those who work in blood banks, and in unsanitary tattooing. Prevention of hepatitis B includes screening donated blood, needle safety, gloves, and education. You can also obtain prevention through active immunization through the hepatitis B vaccination, as well as passive immunization through the HB immunoglobulin. Management of hepatitis B includes the administration of alpha interferon, PEG interferon, lamivudine, and adefovir. Also included in management is bed rest, restricting activities, adequate nutrition, antacids and antiemetics, and IV fluids. Hepatitis C can be transmitted through blood, risky sexual activity, needles, needle sticks, and can be worsened by alcohol use. The standard of management for hepatitis C is the administration of a protease inhibitor, PEG interferon, and ribavirin. In order to get hepatitis D, the individual must have chronic hepatitis B. Hepatitis D essentially acts like a superinfection. At-risk individuals include IV drug users, hemodialysis patients, and those receiving multiple transfusions. The development of hepatitis D leads to rapid fulminant hepatic failure and cirrhosis. Management includes the administration of interferon alpha. The only thing I want you to know about hepatitis E virus is that it occurs in pregnant women in third world countries. This infection is very rare in developed countries. Here's a table to help you compare the different forms of hepatitis. I'll highlight a few important principles. All forms of hepatitis that are chronic can increase the patient's risk for cancer. Only hepatitis A and B have vaccinations available. In the last column, I've listed the serologies that help identify the presence or absence of hepatitis. In general, remember that M as in IgM is immediate, indicating that the patient is infected. G as in IgG is good, meaning the patient is immune. Toxic hepatitis is another form of hepatitis caused by agents such as carbon tetrachloride, phosphorus, chloroform, and gold. This may involve vascular collapse, delirium, coma, seizures, and death from fulminant hepatic failure. Management includes identification and removal of the hepatotoxin, administration of IV fluids, correction of electrolytes, transfusion, and supportive care. Complications of toxic hepatitis include chronic liver disease and cirrhosis. Drug-induced hepatitis is the most common cause of acute liver failure. It can be induced by medications such as acetaminophen, isoniazid, halothane, methyl-dopa, antibiotics, antimetabolites, and anesthetics. Management of drug-induced hepatitis includes the administration of a short course of high-dose corticosteroids and liver transplantation. Fulminant hepatic failure is sudden and severe impairment of liver function developing 8 weeks after the first symptom of jaundice. It's most commonly caused by viral hepatitis, then drug-induced hepatitis, especially with acetaminophen. Management of fulminant hepatic failure includes support in the intensive care unit, liver transplantation, N-acetylcysteine, plasmapheresis for coagulopathy, and to reduce ammonia as well as to stabilize the patient, and management of cerebral edema. This typically occurs with hepatic encephalopathy stage 4. This management can include the administration of mannitol and diuresis. Hepatic cirrhosis is the replacement of normal liver tissue with diffuse fibrous tissue. There are 3 types. Alcoholic is the most common. Postnecrotic typically occurs with acute viral hepatitis, and biliary can occur with chronic biliary obstruction or infection. The manifestations of hepatic cirrhosis can be divided into compensated and uncompensated. I've listed those symptoms for you here. Symptomatic management of hepatic cirrhosis includes the following: antacids, histamine 2 antagonists, vitamins, nutritional support, potassium-sparing diuretics, avoiding alcohol, promoting rest, skincare with lotions, and reducing the risk for injury. It's important to always monitor for complications in patients with hepatic cirrhosis. Medications that may slow fibrosis include colchicine, angiotensin receptor blockers, statins, spironolactone, and immunosuppressants. Primary tumors of the liver are often associated with chronic liver disease, hepatitis B or C, and cirrhosis. Hepatocellular carcinoma, or HCC, is the most common form of hepatic cancer. This often metastasizes rapidly. Assessment of hepatic cancer includes liver function tests, X-ray, CT, ultrasound, MRI, and biopsy. Management includes radiation, chemotherapy, lobectomy, local ablation, and liver transplantation. For these patients, it's important to educate, support, inform, and manage side effects, as well as complications. Hepatic abscesses occur when a pathogen develops a protective wall that leukocytes attack. This produces an abscess cavity full of living and dead cells. Hepatic abscesses are manifested by fever, chills, diaphoresis, malaise, anorexia, nausea and vomiting, weight loss, dull abdominal pain to the right upper quadrant, hepatosplenomegaly, jaundice, anemia, and sepsis. Hepatic abscesses are diagnosed by blood cultures, as well as ultrasound, CT, or MRI guided aspiration. Management includes IV antibiotics, surgical drain, support, vital sign monitoring, and monitoring of white blood cells.